those are much more predictive of polycystic ovarian syndrome than this jawline kind of acne. So I think we sometimes fall into this trap that if you have acne on your lower face, that's hormonal. And if you have acne elsewhere, it's not. And that really just isn't borne out in the data.
Hi, skin friend. Thanks so much for tuning into this week's episode of The Skin Reel. This week, I am talking about a skin condition that has plagued most people listening. I know it's plagued myself and my husband, and now I'm starting to see it in my children. And I am talking about acne. Okay, it is really hard to grow up and live without ever getting an acne lesion. And we all know how frustrating it can be, how it can really affect our psyche and our feelings of self-worth. And then, of course, the sequela of acne, the scarring, the hyperpigmentation, sometimes that can be as damaging, if not more so to people than the actual acne lesion. So to break down all about acne, what it is, how we can treat it, and also to separate some fact from fiction, I've got Dr. John Barbieri with me. He is an acne expert and an assistant professor at Harvard Medical School, and also the director of the Advanced Acne Therapeutics Clinic at Brigham and Women's Hospital, one of my old stomping ground. And he also has incredible educational information on acne and rosacea that he posts on his personal social media channels, which I will definitely include that in the show notes. So if you want to take an even deeper dive into the inflammatory world of acne and rosacea, you can do so. But today we are mostly talking about acne and how most acne, really all acne, is hormonal and what you can do to treat it, prevent it, and also make sure it doesn't come back. If you've ever struggled with acne or you're struggling with acne, you are definitely not going to want to miss this episode. Dr. Barbieri, thank you so much for being here. I love the stuff you are putting out on the YouTube channel, and I've been watching a lot of your acne videos. It's really educational, and I'm thrilled to have you on the podcast to share all your knowledge about acne. So thank you for being here.
It's a pleasure to be here. Thank you for having me.
So you are definitely an acne expert, and I'd love to know how you got into that and why acne.
Yeah, I kind of came into this in sort of a funny way. When I was in medical school and in residency, I was very interested in this kind of health services research, trying to think about how we can provide better value to our patients. And David Margolis, when I was at Penn, he was looking at how dermatologists use more antibiotics per doctor than any other specialty. He was doing this together with the CDC, and he asked me if I wanted to get involved in this work with him because we had this shared interest. And so I started doing that, and we realized acne is this huge use. About 60% of our chronic antibiotic prescriptions in dermatology are for acne, a non-infectious condition. And so together we became really interested in how can we find alternatives to oral antibiotics to help take care of patients with acne. And through that, I kind of just kept doing more and more acne stuff. Eventually ended up being invited to participate in the acne guidelines and to lead that recent work. And I just kept doing acne things over that time and sort of developed this interest, but initially through this lens of antibiotic stewardship.
Well, I've heard that as well. It does boggle your mind that we as dermatologists are prescribing more antibiotics than any other specialty, and not even for true infections. So that's just remarkable. And of course, we're also learning more and more about how antibiotics, even a short course, can really affect your gut microbiome, also your skin microbiome. And we're learning about the importance of that, right? And how that really makes an impact on your overall health.
Yeah, we know that oral antibiotics are associated with not just antibiotic resistance, but people who have long-term exposure to oral antibiotics, they have higher rates of colon polyps, and that might be also associated with colon cancer. So that could reflect issues with the gut microbiome. Individuals, Anna Shan and other groups have shown that when you have exposure to antibiotics, it changes your skin and gut microbiome, and may explain why we get things like strep pharyngitis with oral antibiotic exposure or gram-negative folliculitis. These probably reflect changes to our microbiome from these exposures.
I'm getting a little bit ahead of myself. I definitely want to talk about treatments and what do we do if we can't use antibiotics, but let's just bring it back to the very basics. What is acne?
Acne is fundamentally an issue with what we call the pilosebaceous unit. So it's our sebaceous gland, our hair follicles in the skin. And there's a combination of factors that lead to the development of acne pimples. So whiteheads, blackheads, bigger inflammatory papules and pustules, and then in its most severe form, these inflammatory nodules and cysts. So when we think about what's driving this, well, of course, the oil gland activity, that sebaceous gland, is a key part of that, and that's turned on by hormones. This is how hormones play a huge role in any acne, whether you're a 12-year-old boy or a 35-year-old woman. Hormones play a role in everybody's acne. All acne is to some degree hormonal, and so those hormones turn on the oil gland. That's food for acne bacteria. They start to overproliferate. It can mix together with skin cells and clog up our pores. That's that hyperkeratinization. And then inflammation plays a role too. So some people, they have IL-17 kind of immune response that's helpful, that keeps things under control. Others actually have a dysregulated IL-17 response that leads to more inflammation and more acne lesions. And then our microbiome, as we've kind of alluded to, matters too. Certain kinds of strains of C. acnes are more associated with acne or not having acne. So ultimately, it's about bacteria, our microbiome, about our inflammatory pathways and kind of our tendencies to be able to control that microbiome, skin, hyperkeratinization and proliferation, and then fundamentally hormones that are turning on that oil gland.
Yeah, I think that's such an important thing to mention. A lot of times people think acne is just something that affects teenagers. And yes, we are seeing huge surges in hormones during that period, but we see acne in neonates, right? Neonatal acne. And I just had a lady see me and she was lamenting the fact that she's in her 70s and she's still getting acne breakouts and wondering what's going on. So that's definitely a misconception that acne just happens when you're a teenager, and that hormonal acne that you might get midlife is totally different or unrelated. So thanks for clearing that up.
Yeah, I mean, when you look at the epidemiology of acne, 50% of women, 30% of men have acne in their 20s, about 30% of women in their 30s. So it's not uncommon for acne to persist or even start in adulthood.
I definitely struggled with acne as a teenager, and it really affected how I felt about myself. I did not want to raise my hand. I didn't want to draw attention to myself. And thankfully, it was treated without a lot of scarring afterwards, but that can also leave lingering scarring. And I know they've done studies too that show people with acne, they are treated worse at job interviews. They're less likely to get jobs. That there's definitely this social stigmatization of acne and even the scarring with acne.
We've led some of that work where we showed people, they were randomized to see a picture of someone or a picture where we digitally enhance it to have acne. So the only difference between these pictures was the presence of acne. And when we did that, when we show the pictures of acne, especially severe acne, people are less likely to want to hire that person for a job, to be in a photo with them, to be friends with them. They view them as less intelligent, less hygienic, all of these things. So there's clear stigmatization of those with acne in the community. And it highlights the importance of trying to address that stigma and also making sure that we have appropriate access to treatments and we take care of these people so that they can avoid these negative downstream consequences, not just to mental health and confidence, but also at school and in the workplace.
I love that I'm actually talking to the source of that study.
I'm glad we're able to do that so we can try to, make sure that people understand the importance of acne. It's not just, some people view it as like a cosmetic thing, but it really does have very meaningful impacts on people's lives. And thus it's, an important thing that deserves our attention, and insurers need to make sure they cover treatments for it as well.
Yeah, I was going to say, not just some people, insurance companies, right? They may cover your prescription medication, but they won't cover perhaps the newest laser to help with acne or chemical peels to help with acne, or certainly not treatments for scarring, which is unfortunate because it's not a cosmetic condition. It really is a chronic inflammatory skin condition, and it can really have detrimental effects on people.
Yeah, 100%.
Let's talk about hormonal acne in middle-aged women, because I know a lot of people listening fall into that demographic. So how is that different, or is it different from other acne? Why does it happen, and what can we do about it?
Yeah, these are all important questions. I think one of the first thing that comes up is this idea that adult persistent acne, so people who have acne as an adolescent and keeps going into adulthood, or adult onset acne, people who didn't have acne as an adolescent and started, are fundamentally different from adolescent acne. And there absolutely are people who have this kind of different pattern of acne where it's more along the lower face or things like that. But that's actually a minority. Brigitte Breno a few years ago conducted a study of several hundred individuals with adult acne. And what they found is that acne itself, how it looked, where it happened, all of those things, 90% of them looked just like adolescent acne. And only 10% of them had that kind of lower jawline type of pattern. In addition, if we think about what predicts things like polycystic ovarian syndrome, this hormonal disorder that might be associated with acne, that lower jawline acne is actually not predictive of it. Things like having hirsutism, dark hairs on the chin or chest, having acanthosis nigricans, this thickening of the skin on the necks or in the armpit, those are much more predictive of polycystic ovarian syndrome than this jawline kind of acne. So I think we sometimes fall into this trap that if you have acne on your lower face, that's hormonal, and if you have acne elsewhere, it's not. And that really just isn't borne out in the data. People who have hormonal drivers of their acne, that's first off everybody, but it doesn't necessarily have to be in one of these patterns. People who have acne on their lower jawline can respond to non-hormonal treatments. People who have more of an adolescent pattern of acne can respond to hormonal treatments. And we know that, right? Clascoterone anti-androgen works in teenage boys and teenage girls. Birth control pills, spironolactone, they work in adolescent and adult populations. So I think sometimes we put ourselves into this box of like hormonal adult acne and quote unquote non-hormonal other acne. And I think it limits our treatment choices unnecessarily.
Let's talk about that, treatment choices for someone 35 to 40 who perhaps has quote unquote hormonal acne. They're getting acne. They didn't necessarily have it before, but what are some treatment options for someone like that?
Yeah, we have a bunch. I think they range from topical things, pill medicines, procedures, and kind of lifestyle diet type changes, I'd say would be the main categories. If we think about individuals who have kind of adult persistent or adult onset acne, it tends to stick around for a while. Like unfortunately, these people often have acne for years. And so in my experience, treatments like oral antibiotics, while they can absolutely be helpful, and for some people they are the best treatment, they're often not optimal here because people, they're on them, they're better, they stop them, they're worse. And so they get stuck on antibiotics for years and years. And I think most people, including ourselves, probably don't want to be stuck on antibiotics for years and years. So for those who have more inflammatory acne and need a pill medicine, which many of these individuals, I think they have more inflammatory acne, they need something that's going to work from the inside out. That's where things that do address that hormonal pathogenesis of acne, things like spironolactone, things like combined oral contraceptives, can be incredibly helpful to complement kind of our classic topical multimodal regimens that have things like topical retinoids, benzoyl peroxide, topical antibiotics, and now we have a topical anti-androgen clascoterone. So I do think for many of these individuals, something like spironolactone or combined oral contraceptive is a really valuable and useful treatment in combination with topical regimens. For more mild acne, certainly topical things alone can work, but I find a lot of times this adult population, they need stronger treatments. And so something like that can be helpful. Or Accutane, even isotretinoin, when we think about systemic treatments, that can work very well in this population as well.
Dr. Barbieri, I wanted to just ask, so in someone of that age, do you worry about putting them on oral contraceptives if they're a non-smoker and no history of blood clots?
There are a number of risk factors for people who are at higher risk of problem side effects from combined oral contraceptives. And the main ones would be kind of people who have heart disease problems, high blood pressure, people who have a first degree relative or personal history of blood clots, people who have migraine with aura or heavy smokers. And many of the people we're seeing with acne don't have any of those risk factors, so would be appropriate to consider for combined oral contraceptives. And I think as dermatologists, we should feel comfortable using them. We certainly want to work together and collaborate with our gynecology colleagues to help take care of patients with acne, but we shouldn't be afraid to start combined oral contraceptives, especially as we prescribe so many teratogenic medications too, like isotretinoin. So, we want people to get the full range of contraception counseling, but we should feel comfortable doing these things as well, I think.
And I know sometimes patients are worried about that. I see this whole community out there online that say birth control pills ruin their acne and caused all these problems. So patients are worried about it too. So it's important that we can give them good information on what's safe and what's the best for their acne. And I personally love spironolactone, so I'm glad you're bringing it up. It's an old drug, but I feel like we're seeing an increase in its use. And I think that also is in part because the blood monitoring seems to have gone away, so it seems to be easier to prescribe, and we have better data showing that it's actually really safe and effective.
Yeah, I think if you look, when I started doing this work, people used about 7 times as much oral antibiotics as spironolactone for women with acne, and now it's getting a lot closer to 1-to-1. So there's been a lot of growth in use of spironolactone. I still think we could even maybe flip that further. There may be opportunity to use it more. We're getting more and more data. We have the SAFA trial from the UK and the SPASTI trial from France, so we can talk about some more if we want to, demonstrating how well spironolactone works and how it compares favorably to oral antibiotics for long-term management of acne. So I think we're getting increasing data to support that it works. As you alluded to, we have more data now about the safety of it, that it doesn't seem to be associated with risk of breast cancer. that it doesn't seem to be associated with, in at least young, healthy individuals, with increased risk of hyperkalemia, so we don't need to do as much blood work. That being said, when we do blood work, a pattern I see happen is that we check the potassium months after people start. And if you think about it, the reason we're supposed to check potassium is to look for, acute issues where you could get issues with heart arrhythmias and things. So if we're going to check potassium, we should do it a week or two after we start it. So while many people don't need potassium monitoring, for those who have risk factors or who together we decide we want to do it, we should be checking that a week or two after we start spironolactone, not 3 months later, which is what I often see done in practice. So that's, I think, an important kind of evidence of practice gap for those in the community who are using it.
Because if you have high potassium, your heart's not going to be able to withstand that for 3 to 4 months, right, before you check it.
You'd want to know that right away, not 3 to 4 months later and have some risk of a problem in between. So if we are going to check it, we should check it, a week to two after kind of whatever peak dose you're going to use is, and not wait months to have them come back and check it. So I do think that's an important thing for those who are checking it. But as you point out too, for young, healthy individuals, it really is of low value. And I don't think we need to do it for most people that are taking care of it.
Tell me more about the new, because this has come out since I've been in practice, the new anti-androgen cream for acne.
We've talked about anti-androgens a bunch, and unfortunately, oral anti-androgens we really can only use in female patients with acne because spironolactone can cause gynecomastia, breast development in men, so that's usually not a favorable side effect that anyone's interested in. And birth control pills combined with contraceptives are just for female patients. So clascoteron's great because now we have a topical anti-androgen. If it works from the inside out, it could work from the outside in too. And we can use this in both male and female patients. So it's not just for women. We can use it in adolescent boys as well and adult men with acne because it's rapidly metabolized in the skin, the cortexolone. There's no systemic hormonal effects of it. So it's not going to have any systemic anti-androgen effects, just local in the skin. And it seems to compare favorably to other topical treatments. In terms of efficacy and network meta-analyses, it seems on par with everything else, kind of topical retinoids, topical antibiotics. And from a side effect standpoint, very well tolerated. It doesn't cause irritation, which is often a limitation with their topicals. I do think it can cause a little bit of flaring or purging when people start it, which is an important kind of counseling point with it. But in general, very safe and well tolerated, effective, can complement our other acne regimens. So we can add it to that multimodal kind of therapeutic strategies if we need a little bit extra. Or for people with more sensitive skin, it's a great option to be able to avoid the challenges we run into with topical retinoids, benzoyl peroxide, salicylic acid. So it's a really valuable addition to our treatment armamentarium.
Do you find that insurance will cover it, or do you have to fail other things before you can use it?
I think like most brand new treatments that often there's a step therapy. I mean, there's step therapy for tretinoin in the United States with how crazy our insurance has gotten. But for clascoteron, I find in my practice that people have done a topical retinoid, a topical antibiotic, and benzoyl peroxide, which many people have done even when they first present to us, that you can get it covered. So I do find I'm often able to get it covered. There are also some, of course, just like a lot of these brand products, there are certain copay assistance programs if you send things to the right pharmacies that can help make things more accessible for patients as well.
I love hearing that we have something like this because a lot of people, they don't want to take systemic medication. They don't want to have to take a pill every day. They're worried about side effects or complications. And to be able to have a topical therapy that works and is perhaps even less irritating than some of the ones we have, I think it's so cool. Now, would you use this with a tretinoin or a retinoid? I'm picturing you use it maybe in the morning in lieu of like a clindamycin benzoyl peroxide and use your retinoid at night. How do you typically dose it?
I think you can absolutely use it together with other things. So you can use it either if you want to, let's say someone has very sensitive skin. Maybe instead of giving them tretinoin, you give them clascoteron because they had irritation with tretinoin. So you can use it in lieu of an irritating topical in someone with sensitive skin. For someone, let's say they're on a retinoid, benzoyl peroxide, and an antibiotic, and they're not at their goals, but they don't want to go onto a systemic medication, it might be a nice thing to add to get them that extra bit. Maybe someone who has polycystic ovarian syndrome where you know that hormones are playing a bigger role in their individual acne, it might be a more effective treatment in that group. So we don't have a lot of data about this, but you might hypothesize that it could work better in certain populations. So I view it as a complementary treatment option. It really does need to be twice a day. Ideally, in the clinical trials, once a day doesn't work as well as twice a day, and that is a limitation of it. It's a little bit of a thicker vehicle. It is a twice-a-day medicine, so from a convenience standpoint, that's a challenge. Now, if we're just thinking about how to make a really convenient multimodal topical regimen, we now have a triple agent fixed combination product of clindamycin, adapalene, benzoyl peroxide. You could do that in the morning, then clascoterone, and then at night you do clascoterone again. And that's relatively few steps, and you've hit all of the 4 major prescription topical categories with just 2 products. So I do think there are ways to make practical regimens out of these things, but you're right. Clascoterone, one limitation of it is that twice a day application.
That's really good to know. And yeah, I don't like to have a 1,000-step skincare routine. I don't think people do. So if we can combine them, even better. So I love that. What about for someone who's got pretty mild acne? They don't even really feel like it's bad enough to go see a dermatologist. What's kind of like a good over-the-counter regimen someone can do if they get acne here and there, but not super inflammatory, bad enough that they need to see a dermatologist?
Yeah, great places to start over the counter. We now have a topical retinoid over the counter, adapalene, 0.1%. There's a few brands that sell it. So that can be a great starting place. With topical retinoids, we want to start them slow. So usually every other day at first and try and work your way up to daily over a couple of weeks to avoid having irritation or purging of acne. So that can be a great starting place for people over the counter. Also benzoyl peroxide for the face. I like to try to avoid going higher than 4 or 5% because it doesn't seem to work better, but it has more irritation. So 4 to 5% benzoyl peroxide cleanser that you can use once a day, something like in the shower. Combine that with a topical retinoid. That's a really good over-the-counter starting place for people.
What are your thoughts on like salicylic acid? Do you like that, or exfoliants?
Yeah, I think salicylic acid can be another helpful treatment. I think it's not as effective as benzoyl peroxide. So if you're going to pick like one kind of wash cleanser thing to do, I usually prefer benzoyl peroxide over salicylic acid. But you can, of course, do them together as long as your skin's not getting irritated. So I do think salicylic acid cleansers and toners can be useful, especially for people with more oily skin. That can be nice because it does help to kind of get rid of some of that oiliness. So for those who, like, you wash your face and 30 minutes later your skin feels oily again, sometimes salicylic acid products can be useful there. For those who get those sebaceous filaments on the nose, that kind of blackheads on the nose stuff, salicylic acid products can be helpful at getting those out and breaking them up. So that can be helpful. Alpha hydroxy acids like glycolic acids, those can be helpful, especially for dark marks. I think of them more as like a adjunctive thing together. I don't think it's a foundational acne treatment, but can be part of a regimen, especially to help with dark marks that are left behind.
I really like the peels, the alpha hydroxy peels for the discoloration that you can sometimes get, that post-inflammatory hyperpigmentation. That works nicely.
Yeah, I think, that's a huge issue. People, especially those with, darker skin tones, sometimes the marks, those dark marks or red marks that are left behind can be worse than the pimples themselves. And so it is really important to make sure we're addressing those. And topical retinoids, especially more potent ones, can be very helpful there. Things like glycolic or salicylic acid, either toners, peels, depending on your setting and what you can do, can be really helpful. I'm using things like tranexamic acid or other lining ingredients like kojic acid can also be really helpful strategies to address those dark marks. And fundamentally, it's about treating the acne. If you treat the acne, you'll stop getting the dark marks. And if you don't, you're going to keep getting them. So having a really good acne regimen, and sometimes I'll use stronger treatments than I otherwise would for those who get dark marks to make sure we really control that well.
Yeah, that's a good point. There's really no point in treating your acne scars and the hyperpigmentation if you are still getting ongoing acne outbreaks. It's going to be just a very frustrating experience. So really manage the acne first, get that under control, and then you can manage the side effects of it, the sequela of it with the scars and the dark spots. Well, speaking of, let's talk about like the big gun for acne, right? Isotretinoin. And I feel like this could be a whole podcast episode in and of itself. I personally think it's an amazing drug. I have seen it help so many people with really, really severe acne, but there are so many people who are very, very scared of it. So can you just tell us a little bit about isotretinoin and just give us the facts?
Let's start with how well it works, because that's a good starting place. So 4 out of 5 people who do a course of isotretinoin, which is usually about 5 to 8 months in length, have a lasting remission of their acne. There's no other acne treatment, cream or pill that does this, that can really cause a true remission. So a very special property of it. There's no medicine we have in dermatology that works as effectively as isotretinoin. So almost anybody you can get to clear skin with this who might not be able to clear with other medicines. So really effective, and has this cool special property if it can give a lasting remission. That sounds awesome. Why doesn't everyone use this? What's the catch here, right? And so the challenge with this drug is that it does have some meaningful potential side effects. Everybody who's on this medicine gets dry skin, and that's dry lips, sometimes dry nose or dry eyes or other dryness. It usually improves when people stop, but there are some people where this dryness can persist to a lesser degree even afterwards. So that's a very important side effect to consider. About 5% of people get some joint or muscle aches. That gets better when people stop, and usually a lower dose can help address it. And then rarely there are these important side effects, and these are what I think often people are especially afraid of, which are things like mood changes. I do think isotretinoin can cause mood changes where people take it, they're more irritable, they have mood swings, or they feel sad, and they stop and they feel better, they take it again, and it happens again. So I really think this can occur. However, when you look at the data on people on average, they get happier. And why is this? Because it's a really good acne treatment. So the expectation with this is that people are going to be less depressed, less likely to take an antidepressant, even less likely to commit suicide than people who are treated with other acne therapies. So from a decision of should we do it or not, if people have depressive symptoms, that's for me a reason to use it, not to be afraid of it. But I do think we have to watch out for these individuals who get these unpredictable mood changes, because I think that is a real side effect. And then the other thing that often comes up is the lab monitoring stuff, where people are here like, this medicine needs blood tests, and that means to me, this medicine is dangerous. I think that's one of the reasons it's so important for us to be thoughtful about lab tests. It's not just the cost and the pain of it, but when we do lab monitoring, it implies something is dangerous to people, and then they get nervous. And when we actually look at the data, nobody really has meaningful lab abnormalities on this drug. I think over time, we're going to see a similar narrative to like what we've seen with spironolactone, where we've been checking a lot of labs, but it doesn't actually help us take care of people better. It doesn't help us avoid side effects. It doesn't help us guide dosing. And if we're checking labs and it's not doing any of those things, why are we doing it? It's a low value practice. So, we did a Delphi a year ago that suggested just checking labs at baseline peak dose. And I wouldn't be surprised if over time we even start to have less monitoring than that. So I do think that need for lab monitoring has gone down a lot from what people were doing 10 years ago.
Oh, yeah. I mean, I used to order so many lab tests, and then you might notice a little drop in one thing, and then you got to follow it, and then you're worried, is this related or not? So yeah, I think I agree with you. It's going to be like spironolactone, where we're like, oh, you're healthy, we probably don't need to check. But what do you typically check? Like lipid panel, LFTs?
Yeah, what I'll check is I'll check at baseline, I'll check an AST and an ALT and a lipid panel, and then I'll check it again at peak dose. That's kind of my standard practice. Though for people who really want to avoid lab monitoring, I think that's a reasonable practice as well. And the reason I check those, the lipids, because we know everyone's cholesterol goes up on this medicine and goes back down afterward. The concern is if you get really high triglycerides, which can happen in less than 1% of people, could you be at higher risk of pancreatitis? So that's the rationale for that one. And then LFTs, honestly, I don't think there's much value to AST and ALT, but it's sort of the standard practice what people are doing. And when you look at the data, it's just as common we have normal before people start is on drug, which kind of suggests background noise. No one's ever had a true lasting hepatic injury from this medicine. So despite, tens of millions of people being treated. So I think the value of that is as close to zero as you can get pretty much, but I still do it just because it's a little hard to break too much from what other people are doing. But so I do a lipid panel on AST and ALT. I know some people talk about checking a CK because of this concern about, rarely this medicine can cause a muscle injury thing called rhabdomyolysis. And so they want to check CK to look for that. The problem is like if you go for a run, your CK goes up. You just check CK in 20 people, 5 of them are going to have elevated CK. And so it becomes a lab with an incredibly high false positive range, just not practical to use it in clinical care because you're going to be having all these numbers you're treating and it's never going to be relevant, basically.
I'm glad I'm not going too rogue if we check the same blood work. Now, let's talk about something that is a real side effect of isotretinoin, and that's the issue with birth defects and checking pregnancy monitoring. Can you elaborate on that a little bit?
Yeah, so the other important risk of this medicine is that it can cause really severe birth defects. So in people of childbearing potential, we have to be very thoughtful about how we're going to prevent pregnancy while we're on the medicine. And so in this country, in the US at least, we have this program called iPledge that requires individuals who are of childbearing potential to get monthly pregnancy tests while they're on the medication to ensure that they're not pregnant and to either attest to abstinence or 2 forms of contraception.
That is actually the main, I would say, the real risk with isotretinoin. You cannot get pregnant on it. You can't donate your blood. That's like a no joke side effect. So in some ways, I actually really enjoy using this medicine on people who are either before they are at the point of having sexual activity or they are no longer able to get pregnant or certainly being more careful. So yeah, I think that really scares people. And the suicide ideation also question whether there's linkage with inflammatory bowel disease, which seems like that has not turned out to be real either. So
yeah, that inflammatory bowel disease is another common concern people have. I mean, if you think about your choices, oral antibiotics are often an alternative to isotretinoin. Those are clearly associated with risk of inflammatory bowel disease. Isotretinoin, in general, the data suggests either no or a very minimal kind of attributable risk. There might be some small statistical risk, but to an individual, the number of people you need to treat to actually cause harm is very high. So I think, again, from a decision-making standpoint, if your choice is oral antibiotic or isotretinoin, to me, isotretinoin clearly lower risk of inflammatory bowel disease there.
It's so funny to think we have this idea that these oral antibiotics, just because we've used them for so long, we're so familiar with them, we think that they're the safer option. But when you really look at it, they're not. They cause way more side effects. So if you can avoid them and get around using them, it's really, really helpful and better for the patients and better for their acne.
Yeah, I think this is the challenge we get into with side effects sometimes is we go like, oh, I don't like this drug because it has this concern. But you have to think about what's the alternative. It's not just use the drug or not. If you don't use it, you either have the untreated acne or you have to use a different medicine that has its own risks. I mean, if we want to talk about the recent Valisher report briefly about the benzene thing, that's another situation of that where, there is this potential risk of benzoyl peroxide. We should take steps to make it as safe as possible. But it's not as simple as just use it or not, because if you don't do it, well, then you're doing more oral antibiotics or more isotretinoin because you can't get people better at topicals. And then those have their own risks to them too. We have to think about that consequence of making that change.
Yeah, let's touch on that Valisher study just briefly with the benzoyl peroxide.
What happened was this independent testing lab, they took a bunch of benzoyl peroxide products off the shelf. They tested them under a variety of conditions, but they mostly presented data at elevated temperatures, 37 and 50 degrees, this kind of quote unquote accelerated stability testing, though often this is done at 40 degrees and many other settings at 50 degrees, which is an important caveat. And they found when you do this, they develop concerning levels of benzene. And this is not a contamination thing. This is that benzoyl peroxide can break down into benzene. So it's a fundamental molecule issue. And I think, there's some key take-home points from this that we should make sure we're storing benzoyl peroxide according to the manufacturer recommendations. So not having it, at room temperature, or in a cool, dry place. We shouldn't be storing it in elevated temperatures. We should be thoughtful about our supply chain. We should make sure when it's being warehoused and shipped to the store, it's under cold conditions, it's not in a hot truck or a hot warehouse. If we order things from online, actually, we have to be thoughtful to this. If you live in like Texas and you order it and sitting on your porch and it's 100 degrees outside for a day or two, that's developing benzene in there. And so it might be better to go to a store and buy it from a store than order it online, so you avoid that sitting outside depending on, the weather conditions and where you live. So I do think it has some clear implications for how we store and handle it. When it comes to like the actual safety of it or not, at room temperature, when they originally procured them, almost all products had very little or no benzene in them. And a key thing about benzene is that although we don't want to have any benzene in our lives, the reality is we do, and that there's a difference between something being dangerous and something causing true harm or meaningful risk. If you have some tiny amount of benzene that you get exposed to, the likelihood that's going to turn into a hematologic malignancy is basically zero for you as an individual. And the quantities of benzene in these benzoyl peroxide products, even if there is some, like what Valisher found, and there's a whole question of are their methods acceptable, and let's not even get into that, but let's assume they are. Even at those levels, the true risk to you as an individual is probably extremely low. And, just turning on a gas stove or eating food, we get more benzene than in these benzoyl peroxide products. So I do think we have to put that risk into context. We should make these products as safe as possible, but we shouldn't overreact either.
Thank you for clearing that up. Yeah, don't store it in your car. Be thoughtful about if it's in a hot place or, right, to your point, if it's sitting out on your Amazon box on your porch in Georgia, right, from about May till October, it just gets too hot. So be mindful of that. Look at expiration dates. I'm amazed how many people don't realize that these products do have expiration dates. And if they're old and expired, throw it out and get a new one, especially with benzoyl peroxide.
Yeah, I had someone the other day run their products and they had a benzoyl peroxide clindamycin jar from 2013. And I was like, maybe it's time for a new one.
Oh my gosh, but I can see how that happens. I look in my cabinet, stuff I never use or has been sitting there and, a year flies by and next thing you know, it's expired. So be sure to look for those dates. And I do think it's safe to use. I still recommend it, but just be smart about how you use it. Dr. Barbieri, I would love to know about food triggers for acne, because I feel like this is also something that I hear a lot about. And just a quick funny story, my husband several years ago was trying to increase his muscle mass. So he bought this massive thing of whey protein, was mixing it with everything. And then all of a sudden, he started getting this very severe nodulocystic acne. And this is someone who I don't think had ever had a pimple even as a teenager. And it was really, really severe. And it took me as a dermatologist a minute to associate what was going on here. So please share your knowledge about food and acne.
So whey is one of those ones that I think in many case reports, taking large quantities of whey is associated with acne. And so for those who are, dealing with acne, trying to use a non-whey protein supplement is probably a good idea. If you think about it, like the amount of whey in like a protein, shake could be like drinking several gallons of milk, just to put that in context. And we'll get into like milk and acne in a second, but it just highlights how much whey is there. So it is worth considering other protein supplements. I do think whey can be associated with acne. And then more broadly, the strongest association with diet and acne is sugar. So there are several randomized trials that show eating a lower sugar diet improves acne. So to me, and it's good for our health too. In general, sugars, diabetes, all of those bad things. So a really simple recommendation, always easier said than done in doing, as someone who loves eating ice cream and things like that. But nevertheless, less sugar is clearly associated with less acne and better overall health. So that's a simple evidence-based recommendation. Dairy, chocolate, some of these other things are a little bit more uncertain. There probably is some association between these things and acne, but it probably varies from person to person. So I think, if someone tries it and they find it helpful, great. But I do think we should be thoughtful about not like going on some crazy elimination diets where you're creating nutritional problems or just making yourself miserable in the pursuit of fixing your acne, because I often find that these interventions aren't that helpful. So I think less sugar, really good. For certain people, less dairy, less chocolate, less whey may be helpful, but, see how your body reacts to these things. And, I don't think we need to like make our lives miserable avoiding our favorite foods in the pursuit of trying to treat our acne this way, because I often find it's not successful.
And it can make you more stressed out. And then when you're stressed out, you have increased cortisol. So it can then trigger more acne. So yeah, I think just be reasonable, try cutting out or lowering the amount of sugar. I also have a sweet tooth myself. So it's impractical to think it's going to be totally gone out of my life, but I am more mindful about it, not because I'm breaking out, but just for my overall health in general. And my husband did have to stop his whey proteins.
Well, fortunately, there's a big market of other alternatives. So hopefully you found something like, the other dietary thing that's to think about are some of the like supplements and vitamin side of it. So, there is some evidence that people with acne have lower levels of vitamin D. And in that setting, if you supplement vitamin D, that can help. There's some evidence that vitamin B5 can be helpful for acne, and zinc as well. So those can be things that someone could consider trying. They're relatively low risk and safe as long as they're not causing stomach upset for zinc, things like that. So those, I think, are reasonable other things to consider. But a word of caution, I think, are these vitamin A supplements that are out there. I've just seen more and more of these supplements that they don't say it. They're called like Acne-tane or something. It sounds, or Acne Away, or, they sound like just some generic supplement that's going to help my acne. You turn it around, you look on the label, it's got 1,000% your daily value of vitamin A. And what you're doing there is you're really taking low dose isotretinoin. And often the people who are doing this are people who want to avoid isotretinoin. And they're unknowingly, because of sort of this marketing and this lack of transparency, they're basically doing the thing they want to avoid with all of the risks of doing that. So I really do encourage people, if you're going to do supplements, to look out for these things that have really high percentages of vitamin A that often, it's not obvious when you buy it, that's what's there, because those can have the same kinds of risks we worry about with isotretinoin, with Accutane.
Yeah, like isotretinoin is a vitamin A derivative. So taking copious amounts of supplements with vitamin A is not a safe alternative. And neither is eating a ton of carrots. Can you back me up on that?
Yeah, I think anything in excess, you have to worry about, no matter what kind of, however good it might be as an individual food. If you go overboard with it, it's probably not the best.
That's right. Even too much water can kill you. I remember that just like blew my mind. Well, Dr. Barbieri, this has been a lot of fun. I've learned a ton of stuff. Are there any new treatments out there for acne? I know we talked about clascoterone, but what about laser? Do you have any familiarity with the new laser for acne?
These are exciting too. So we now have these 1726 nanometer lasers. There's 2 brands on the market, AviClear and Acure, and they work by targeting the oil gland in the skin. So we talked about isotretinoin earlier, and the reason it can give a lasting remission is that it shrinks the oil glands. That's why it causes lasting clearance of acne. These lasers are doing the same kind of idea. And so in my mind, they can have some of the benefits of isotretinoin without some of the risks. We worry about systemic side effects of hurting our other oil glands or doing other things. So I do think they're really helpful, valuable treatments. They certainly are not right for everyone. They're not as effective as isotretinoin. They're definitely not a replacement for it. But for those who are looking to avoid creams or pills or other treatments, I do think that they can work well. They can give, I think, a durable improvement in acne. We only have a few years of data so far because they're so new, but they seem to be able to do that. So I do think they're an exciting new option for people who can access them and are interested in them.
To me, the biggest hurdle for people is probably the cost because it's considered cosmetic. It's not covered by insurance. And so you are going to be paying out of pocket for it, which may not be something that a lot of people can do. But for those who can and want to avoid systemic treatment, I think it's a great option to be able to do that. Super cool that we now have wavelengths I can target those sebaceous glands specifically. I love it. Dr. Barbieri, this has been so much fun. I've learned a ton. Can you just share with us your top 3 takeaways for someone listening? They're struggling with acne. Top 3 things they should be aware of or think about.
Yeah, I think thing number 1 is all acne is hormonal, whether you're a 12-year-old boy or a 35-year-old woman. Hormonally directed treatments can be helpful for anyone, and treatments that aren't hormonally directed can also work for almost anyone. So we should keep an open mind about what treatments can work for people and not put ourselves into boxes where we think there's only one kind of treatment. We should individualize it to the person. So that'd be thing number 1. Thing number 2, I think, is to not forget about the sequelae of acne. So scarring, dark marks, red marks, that the most important thing in all of these, I tell people number 1, number 2, and number 3 to getting this better is to treat the acne. So of course we have to do that, but to make sure we're thinking about what kinds of treatments might also help with these marks and acne. What kinds of other things can we add to the regimen to address these? So I think not forgetting about those is especially important because people often are more bothered by those marks than the acne themselves. And then thing number 3 is to make sure we're being kind of multimodal in our way of treating acne. I see a lot of people who they kind of like collected a whole bunch of like, this is the best thing. And they've got like 3 retinols and like a whole bunch of things that overlap in their mechanism. And what we want to do is find things that complement each other. So that address these different acne factors. So things like topical retinoids and retinols, things that address the microbiome, like topical and oral antibiotics, or benzoyl peroxide, things that can address hormones like clascoterones, spironolactone, combined oral contraceptives. So to think about combining treatments with multiple mechanisms of action to really control acne well.
Yeah, coming at it from multiple different angles to really get the best benefit. I love that. Well, Dr. Barbieri, you have an amazing YouTube channel where you go into a lot of detail on these topics and acne. Where can people find you if they want to subscribe to your YouTube channel and follow you and listen to your great content?
We have some content on Twitter, YouTube, on Instagram. It's like basically my name at Dr. John Barbieri. So feel free to check that out. I've got hours and hours of content, so we couldn't all fit it in here. But if you're interested in learning more about acne and also rosacea, feel free to check those resources out.
I will definitely include that in the show notes so people can easily find you. And thank you so much for your time. This was a lot of fun.
Yeah, thank you for having me. It's been a pleasure.
We'll see everyone next week.